Oral Health and Palliative Care, Series 9. Oral health and palliative care. Persons at the end of life require special attention to their rapidly failing oral health. 89% of those terminally ill with cancer will complain of at least one oral symptom. General health and comfort are closely linked with oral health in the terminal stages of these diseases. And they may be related to the direct effect of the primary disease, the indirect effect of the primary disease, treatment of the primary disease, and direct or indirect effect of coexisting diseases. What are the oral health issues at the end of life? It can vary from person to person, but these are the most common and they can occur in combination. Remember from the previous slide that they can be due to the direct effect and the indirect effect of the primary diseases. It could also be due to the treatment of that primary disease, the direct and indirect effect of the coexisting diseases, its treatments, and of course a combination of all of these above. So we're looking at dysphagia, which is swallowing difficulty, aspiration pneumonia, nutrition, hydration, and taste alterations, sore lips, denture issues, thick mucus, difficulty speaking, pain, but also stomatitis, mucositis, xerostomia or dry mouth, nausea and vomiting, candidiasis, also known as thrush, oral hygiene issues, infection, and those many other things. Let's take a closer look at how oral health issues and palliation are interrelated. No doubt from this diagram, which you see there's many arrows that are moving from one issue to another. It's a complex issue and many issues leading to further issues. I've added dysphagia, aspiration pneumonia, and infection on both sides, and these, of course, are interrelated to many of the things that are going on in this diagram. I've circled xerostomia and boxed in pain. These are very important issues for those who are receiving palliative care treatments. The first thing I'd like to talk about is candidiasis or oral thrush. The incidence is about 90% of patients who are undergoing cancer treatment will experience this. The most common form of candidiasis is thrush. It's painless white strands or flecks or patches that seem to resemble milk curds that adhere firmly to the underlying mucosa. And if you try and scrape them off, it may bleed. Lesions may develop in any part of the mouth, but most often the sides or the dorsum of the tongue, buccal mucosa, gums, and oral pharynx are where you're going to find it. Acute atropic candidiasis from antibiotics with patchy loss of papillae on the tongue and with painful erosions or on the oral mucosa is another area. Risk factors and clinical findings will see candidiasis for those persons undergoing chemotherapy and radiation therapy, antibiotic treatments, treatments with corticosteroids, and those who are smoking, and xerostomia with a dry mouth. Dry mouth, xerostomia. As mentioned before, it can be a specific complaint that patients or residents will be experiencing. Up to 40 to 77% of palliating patients will complain of this. And when we get to the terminal stages of their illness, it almost affects all cancer patients. So the main causes of a dry mouth are medications, those that are prescribed and those that are over the counter. There's well over 500 medications that can cause xerostomia. And when you have at least 3 medications that a patient is taking, it significantly increases the probability of them experiencing xerostomia. And there are many, many other causes that could be the coexisting diseases that the patient or the resident has, such as diabetes. It could be anxiety, depression, stress, as we mentioned, part of the chemotherapy, the cancer. These are many things that can cause dry mouth. And dry mouth impacts not only on their health, but the overall quality of life of that person. They will experience difficulty with chewing, swallowing, and tasting. They have difficulty wearing their dentures, suffer some nutritional issues because of eating softer foods. burning sensation in the mouth or on the tongue, difficulty speaking, may have some difficulty esophageal dysfunction, including chronic esophagitis, increased intolerance to taking medications, bad breath, glossitis, candidiasis, angular cheilitis, and bacterial infections. Also, an increased risk of loss of tooth structure due to attrition, abrasion, and erosion. Loss of their oral buffering capacity, which leads to an increased risk of mucosal injury. Markedly increased susceptibility to dental caries, that is tooth decay, and overall decreased socialization. Oral mucositis. The definition of oral mucositis really is painful sores and inflammation in the mouth. It's an inflammatory or ulcerative reaction in the oral cavity. Mucositis is the most common complication of intensive cancer chemotherapy and radiotherapy and bone marrow transplants. Patients or residents with chronic gastric reflux, xerostomia, poor nutrition, poor oral hygiene, or those who are older, smoke tobacco, or drink alcohol are also at increased risk to develop mucositis. About 50% of cancer patients receiving the radiotherapy to the head and neck will develop mucositis, and this occurs in the second week and lasts for about 6 to 8 weeks. Above that, chemotherapy and radiation therapy can cause, as mentioned previously, oral mucosal changes and cellular death. And again, this is a common side effect and occurs 3 to 10 days post-treatment, and then it improves. It can also affect their taste. Just showing you here in this slide that there actually are several grading systems and scales for assessing oral mucositis. And I've put a table here up that shows you in the far left column the different scales and then their corresponding grading systems. Taste. Changes in taste often happen, and what we're seeing here that the causes are a decreased regeneration of the taste buds as a result of the chemotherapy and the radiation therapy, the direct effects of the cancer itself on the oral cavity, the drugs or the medications, other local things that are going on in the mouth, such as dry mouth and candidiasis, nutritional deficiencies such as low zinc levels, and other things like metabolic disturbances, including renal failure, diabetes, and adrenal insufficiency. As a result of this, the taste and enjoyment of eating are really important factors in the overall quality of life for that person, and a loss is experienced as a result of that. The distortions in taste can make eating very unpleasant, and the taste of food itself stimulates salivary secretion and gastrointestinal mobility. So abnormalities of taste can lead to a decreased nutritional intake and impaired digestion. Bad breath or halitosis may be a serious problem for those who are undergoing cancer treatments or those who are terminally ill, because it creates a barrier between them and those around them and may worsen their social isolation at the end of life. Common causes of bad breath in the oral cavity can account for the majority of the cases. So we're looking at poor oral hygiene, throw in a little bit of dry mouth or xerostomia, and that sets it up for periodontal and gingival disease. We're looking at infection, we're looking at the tumor itself being a cause if it's in the oral cavity, also bleeding within the mouth from infection, tumor, or chemotherapy. In the respiratory tract, we could be looking at chronic sinusitis, necrotic tumors in the throat and in the lungs could be a cause of bad breath. Person may have gastrointestinal problems, renal or hepatic failure. Assessment. As part of your overall assessment, you should be including oral health. What you need to do is to identify the oral concern that the palliating person is experiencing and note some of the other key pieces of information. So take a look at whether they're experiencing dryness of the mouth, whether there are sores, whether there's pain, bleeding, changes in taste, difficulty swallowing. When did they have their most recent chemotherapy or radiation therapy? Look at the list of medications that they're on. What is their dental history? Have they had previous periodontal diseases? Are they wearing dentures right now? And if there is anything else that is noteworthy that could relate to their dental problem and treatments that they may be undergoing that could relate to their oral health problem. Dry mouth. I'd like to share some helpful interventions for dry mouth. They are suggestions and may not work for all persons who are palliating, but it's a good start, and you certainly need to tailor the interventions to what will work for that person. So in the left-hand column, there's treatment, and in many cases it'll be an antifungal agent for candidiasis. Stimulate salivary flow is really important, and you can do that through crushed ice, if they're able to chew some gum, food that requires a little bit of chewing, and of course there are some treatments available. We want to replace those lost secretions, so there are saliva substitutes. Could increase their fluid intake, especially during meals, misting of the mouth, and also encourage them to drink milk. You want to avoid substances that will irritate or dry those mucous membranes, things like coffee, tea, citrus fruits, alcohol, glycerin, and tobacco. And you want to protect those teeth because we don't want to develop any cavities. So avoid foods that are high in sugar content. That would be sugary, carcinogenic foods. You want to make sure they've got good oral hygiene going on. Use a very soft toothbrush. Encourage flossing if they can, and fluoride applications. Treat the dehydration with local measures. Sips of water, spraying the mouth, and swabbing the mouth, and prevent the complication of that xerostomia. So you want to have mouth care every 2 to 4 hours and use a chlorhexidine mouthwash. Some general measures that we can do is don't serve the food too hot. And as I mentioned previously, not just acidic liquids, but acidic foods. We don't want to be serving that because that may trigger additional pain in the mouth. Avoid alcohol and tobacco. Moisten the food with sauces for easier swallowing. Chilled or frozen yogurts or ice cream are very good too. Make sure there's infection control measures in place. Mouth care every 2 to 4 hours around the clock. Remove those dentures if necessary. As mentioned earlier, a soft toothbrush. We want to make sure that we're rinsing that mouth on a regular basis, cleaning those dentures and replacing them if they can be tolerated and especially to be used when they're eating. One more thing just to add under mouth care is that there are specialty toothpastes available that have bioavailable fluoride, calcium, and phosphate. One of the things that makes it so good is that even if the plaque can't be removed from the teeth, this toothpaste still has benefits. Plaque acts as a reservoir for minerals, so the calcium and phosphate that gets stuck in the plaque will help remineralize teeth and therefore reduce the risk for dental caries. Check your dental supplier for this toothpaste. Examples of products are X Pure and MI Paste, also ClinPro 5000. Pharmacological treatments, swish and swallow or swish and spit. Morphine analgesics are also available. I'd like to end the presentation on 2 slides that review an oral care protocol for palliating patients or residents. So number 1, remove the patient's or resident's dentures if present and brush thoroughly with a denture brush and appropriate solution. Number 2, with a soft, bristled, small head toothbrush, brush the patient or resident's teeth by placing the brush at the gingival margin so that it's right where the teeth meet the gum line, and make a sweeping motion toward the crowns and biting surfaces of the teeth. Number 3, clean the patient's tongue with a soft brush if possible. Number 4, have the patient or the resident rinse their mouth. And there are a variety of mouthwashes available. Avoid those that contain alcohol, so go for an alcohol-free product. You could consider a hydrogen peroxide and saline mixture or a chlorhexidine mixture. An alkaline rinse composed of salt, baking soda, and water or club soda may also work. Under number 5, if there is a thick mucus, use sodium bicarbonate mouthwash. So that's 2 teaspoons of sodium bicarbonate to 1 liter of water or saline. Thick mucus is a very common problem, and so we need to break up that mucus in order to make sure that the surfaces in the mouth are clean. Number 6, then proceed with brushing. We've put here no toothpaste, just a dampen brush. You could use a toothpaste product, as we mentioned on one of the previous slides, But you need to consider that in terms of whether the patient or the resident is experiencing a significant degree of dysphagia. And number 7, if there is leftover debris in the mouth, use hydrogen peroxide mouthwash. And this is used with a final rinse of saline or tap water. And number 8, we want to make sure that you apply water-soluble jelly to the lips. There are other webinar topics available, and we have those listed here, 13 topics. And there are many additional resources that we have listed here, including best practice guidelines, articles, and websites. Thank you.